Hi, everyone. We're back. We're going to do an overview of the endocrine system. So I'm going to share. So the endocrine system consists of glands that release hormones directly into the bloodstream to regulate various bodily functions, including metabolism, growth, reproduction, and mood. Key glands include the pituitary, thyroid, adrenal glands, pancreas, gonads, and others. The the pathophysiologic mechanisms are that the pancreas controls hormonal imbalances. So there's hyperfunction. Hyperfunction is the overproduction of hormones that can lead to conditions such as hyperthyroidism, excess thyroid hormones, or Cushing's syndrome, which is excess cortisol. Hypofunction is the underproduction that can result in diseases like hypothyroidism, where we have insufficient thyroid hormones, or Addison's disease, where we have insufficient adrenal hormones. We also have receptor dysfunction, where hormones excrete their effects by binding to specific receptors on target cells. The dysfunction can occur due to downregulation or desensitization of receptors, for example, in insulin resistance, genetic mutations affecting receptor structure or function. Then we have feedback mechanism disruption. The endocrine system relies on feedback loops, negative and positive, to maintain homeostasis. Dysregulation in the feedback mechanism can lead to loss of feedback inhibition, resulting in uncontrolled hormone secretion. An example would be primary hyperparathyroidism, and secondary disorders due to pituitary dysfunction affecting other glands, secondary adrenal insufficiency. Then we have tumor formation. Tumors, benign or malignant, can affect hormone production. Functional tumors secrete hormones autonomously, so that would be in insulinomas. And then non-functional tumors can compress surrounding tissues, impacting hormone secretion. Then we have autoimmune disorders. The immune system can mistakenly attack endocrine glands, leading to Graves' disease and Hashimoto's thyroiditis. Then we have metabolic and structural changes. So conditions such as obesity can lead to metabolic syndrome, causing altered hormone levels. An example of this would be increased insulin resistance. And structural changes such as adrenal hyperplasia can also impair normal hormone production. Clinical implications would be hormonal imbalances can manifest in various ways, including changes in metabolism, mood disorders, reproductive issues, and growth abnormalities. Diagnosis often involves blood tests to measure hormone levels, imaging studies to assess gland structure, and management strategies tailored to the underlying cause, such as hormone replacement therapy or medications to correct imbalances. Nursing assessment of the endocrine system involves a comprehensive approach to evaluate the function of various endocrine glands and identify any potential dysfunctions. Here's a structured guideline for conducting this assessment. So, you want to start with patient history. You want to get any medical history. Is there any previous endocrine disorders, family history of endocrine disorders, current medications, including over the counter and herbal supplements? Then we want to review symptoms. Are there any weight changes, gains, or losses? Changes in appetite, thirst, or urination? Fatigue, weakness, or sleep disturbances? Skin changes, maybe dryness or pigmentation? Mood changes, depression, and anxiety? Then we would move to physical examination. We want to assess the vital signs for abnormalities in blood pressure, heart rate, and temperature. We want to observe for signs of distress, fatigue, or abnormal body habitus. Skin assessment, we want to look for changes in color, texture, moisture, or hair distribution. Neck examination, we want to palpate that thyroid gland for enlargement, known as goiter, or nodules. Abdominal examination, assess for organomegaly. Neurologic assessment, evaluate reflexes, sensory changes, and mental status for signs of potential dysfunction. Then we would move to a specific assessment based on gland involvement. So the thyroid function, we want to check for signs of hyperthyroidism or hypothyroidism. Hyperthyroidism might be tremors or heat intolerance, whereas hypothyroidism could be cold intolerance or hair loss. We might want to focus on the adrenal function. So we want to assess for signs of adrenal insufficiency, such as fatigue or hypotension, or excess adrenal function, which would be hypertension or moon phases. Then we can talk about pancreatic function. So we want to monitor for symptoms of hyperglycemia or hypoglycemia. And then lab tests would be hormone levels. So like TSH, T3, T4 for thyroid, cortisol for adrenal function, and fasting glucose, and HbA1c for diabetes. Then we would move to electrolytes, especially sodium and potassium, to evaluate for conditions like SIADH or adrenal insufficiency. We might also get some urine tests, a 24-hour urine collection specifically for catecholamines, cortisol, or electrolytes. And then we could also do some imaging studies. So we would consider referring for imaging studies if we need an ultrasound for the thyroid or adrenal glands, and a CT or MRI for further evaluation of tumors or structural abnormalities. Then for patient education, we want to discuss the importance of regular monitoring and managing any identified endocrine disorders. We want to educate on lifestyle modifications such as diet and exercise and medication adherence. And then we would document all findings accurately, including patient history, physical exam results, laboratory and imaging results, and any patient education provided. So let's do an overview of pituitary gland function. The pituitary gland, often referred to as the master gland, plays a crucial role in regulating various bodily functions through hormone secretion. It is located at the base of the brain and is divided into two main parts, the anterior pituitary and the posterior pituitary. For the anterior pituitary function, we have the growth hormone. This stimulates growth and cell reproduction. The thyroid stimulating hormone, which stimulates the thyroid gland to produce thyroid hormones, T3 and T4, which regulate metabolism. The adrenocorticotropic hormone, ACTH, stimulates the adrenal cortex to produce cortisol, which helps manage stress and metabolism. The luteinizing hormone and follicle stimulating hormone, LH and FSH, regulate reproductive processes, including ovulation in females and sperm production in males. Prolactin, it should also be listed here, and that promotes lactation in breastfeeding women. Now let's move over to the posterior pituitary function. So this is going to be your antidiuretic hormone, ADH, also known as vasopressin. It regulates water balance by promoting water reabsorption in the kidneys. And then we have oxytocin, which stimulates uterine contractions during childbirth and promotes milk ejection during breastfeeding. Clinical implications of pituitary dysfunction. Dysfunction of the pituitary gland can lead to various disorders depending on which hormones are affected. We have growth hormone disorders where we could have acromegaly and dwarfism. Thyroid disorders with hypothyroidism and hyperthyroidism. Adrenal disorders like Cushing's disease or Addison's disease. And reproductive disorders where we have hyperprolactinemia and hypogonadism. And then two things that we will talk about in this lecture is diabetes insipidus and a sudden syndrome of inappropriate antidiuretic hormone. So diabetes insipidus, also known as DI, is where we have insufficient. So we have two different types, central diabetes insipidus and nephrogenic diabetes insipidus. So with central diabetes insipidus, insufficient ADH leads to excessive urination and thirst due to the inability of the kidneys to concentrate urine. And then with nephrogenic diabetes insipidus, the kidneys do not respond to the ADH, causing similar symptoms. Then when we move over to SIADH, so syndrome of inappropriate antidiuretic hormone, is excess secretion of ADH, can lead to water retention, hyponatremia, and fluid overload, causing symptoms of confusion, seizures, and respiratory distress. So now we're going to focus on diabetes insipidus, a condition characterized by excessive thirst, polydipsia, and excessive urination, polyuria, due to insufficient levels of antidiuretic hormone. So we talked about two types, but there's actually three. There's central diabetes insipidus, nephrogenic diabetes insipidus, and dipsogenic diabetes insipidus. With central DI, the cause is going to be a deficiency of ADH secretion from the posterior pituitary. Common causes are head trauma, tremors, genetic conditions, or infections. Nephrogenic DI, the cause is going to be kidneys' inability to respond to ADH, and this could be caused from genetic disorders, chronic kidney disease, or certain medications like lithium. And then we have dipsogenic DI, where we have excessive fluid intake suppressing ADH secretion, and the common causes are psychogenic polydipsia. So here we have the pathophysiology of DI. Um, DI is a condition that affects how your body regulates water. Here's a straightforward breakdown. What is ADH? Antidiuretic hormone is also known as vasopressin. This hormone is produced in the hypothalamus and stored in the pituitary gland. Its main job is to help your kidneys manage the amount of water in your body. Under normal circumstances, when you are dehydrated or have high blood sodium levels, your body is going to release that ADH. ADH will then signal to your kidneys to reabsorb more water, reducing urine output and concentrating the urine. So, what happens when you have DI? There are two main problems. We have insufficient ADH production, so the body does not produce enough ADH. This can happen due to the damage of the hypothalamus or pituitary gland from injury, surgery, or disease. And then we could have kidney resistance to ADH. The kidneys do not respond to ADH properly. This could be due to genetic factors, chronic kidney disease, and certain medications. Because of the lack of ADH or the kidney's inability to respond to it, we're going to have increased urinary output. The kidneys will allow too much water to be excreted, leading to very large volumes of dilute urine, so up to 3 to 20 liters a day. Dehydration, since the body loses more water than it can take in, it can lead to dehydration, causing symptoms like excessive thirst, polydipsia, dry mouth, and fatigue. DI occurs when there's either not enough ADH or the kidneys can't use it. This results in excessive urination, thirst, and the body struggles to retain water and maintain homeostasis. So here you have a nice little card of symptoms. Primary symptoms are going to be the polyuria and polydipsia, and other symptoms will be dehydration, electrolyte imbalances, fatigue, and increased nocturia. Know that one. For DI, our diagnostics are going to be urine osmolality. We want to know how concentrated or dilute that urine is. Serum osmolality, this is going to be elevated due to dehydration. So we need the kidneys to start pulling in some of that water to dilute that. And then water deprivation test is something that we might do, and it will tell us which type of DI we have. And then for imaging studies, we might do an MRI of the brain to assess the pituitary abnormalities. This slide is a little broken. So we have, if we have central diabetes insipidus, we're going to give desmopressin. So it's a synthetic ADH because we're not producing enough. And then your lifestyle changes would be adequate fluid intake. If we have nephrogenic diabetes insipidus, we're going to give thiazide diuretics so that we can enhance that ADH response. And then we'll have them do a low salt diet. And then if we have dipsogenic diabetes, we need to manage the underlying cause, and they might need behavioral therapy for excessive fluid intake. Nursing considerations. We're going to assess fluid intake and output. Super important for this. Know your eyes and O's. We're going to assess for signs of dehydration, look at the mucous membranes, decreased skin turgor, low blood pressure, evaluate the patient's vital signs for any abnormalities such as elevated heart rate or hypotension. It's going to show us we don't have enough fluid in the body. For plan, we're going to plan fluid management. So develop a fluid replacement plan tailored to the patient's need, ensuring adequate hydration. We want to educate the patient about this. So things like medication adherence, recognizing signs and symptoms of dehydration, and lifestyle medications such as that dietary changes we talked about. And then we want to develop a plan to monitor those electrolytes, specifically sodium. And then we're gonna, what are our nursing implications? We're gonna monitor. So we want to use this. We want to use a flow sheet for our fluid intake and output. We want to perform regular assessments and document our findings. We're going to provide that education that we talked about, and we're going to coordinate with the lab for timely electrolyte checks. And then for educate, we want to evaluate our hydration status. We want to assess the patient's understanding. We want to monitor electrolyte levels, and we want to reinforce any education we've given along the way. And now we'll talk about syndrome of inappropriate antidiuretic hormone. This is the excessive secretion of antidiuretic hormone, which leads to water retention and hyponatremia. So before, with um, diabetes insipidus, we didn't make enough antidiuretic hormone. But now with SIADH, we make too much. So it's going to be the yin to the yang here. That's what I want you to know. Causes are going to be tumors, lung cancer, head injuries, central nervous system disorders like meningitis or strokes. Pulmonary causes could be pneumonia or tuberculosis, and certain antidepressants, anti-epileptics, and chemotherapy agents can cause that. And then I have a little bit of a sheet here where you can see the kind of the patho. So with SIADH, we have increased levels of ADH. Renal tubules are permeable to water. We have water reabsorption. So we have low urine volume but high blood volume. Excess ADH causes increased water reabsorption in the kidneys, so it's going to be in the central system, and it leads to diluted serum sodium and concentrated urine. Signs and symptoms of SIADH. Again, here's a little infographic for you. It's not the best, but you can kind of see it. So hyponatremia symptoms are going to be nausea and vomiting, headache, confusion or altered mental status, seizures, coma. Fluid overload symptoms are going to be weight gain, edema, and hypertension. Our diagnostics for SIADH are going to be low serum sodium because that the body's fluid level is overloaded, low serum osmolality, high urine osmolality, urine sodium concentration may be elevated. And we're just going to assess the symptoms and medical history of the patient. We're going to give these patients a fluid restriction, typically 800 to 1,000 mLs a day. For medications, we can give demiclocycline, which will induce nephrogenic diabetes insipidus, so it'll kind of go the other way, and vasopressin receptor antagonists like tolvaptan. We're going to regularly monitor for electrolytes and fluid status with these patients. For nursing, fluid and electrolyte or fluid intake and output is super important, and then those neuro assessments. We're going to make sure that we have a fluid restriction plan. We're going to make sure we educate the patient on the importance of fluid restriction and recognizing symptoms of hyponatremia. And we're going to schedule lab tests to monitor. Again, we're going to monitor those fluid intakes and outputs. We're going to conduct frequent neurologic assessments and document findings. And we're going to continue to evaluate the fluid status, assess understanding, monitor those lab results, and reinforce education. I found this infographic here and I really liked what it had to show. It's really your concept map right here, but use this to study. It just really helps you understand. I like these little infographics when you can see what the patient might look like. I feel like that is really helpful when I'm taking tests. And then I have another one here of DI versus SIADH. All right, so now we're going to dive into an overview of pancreas function. The pancreas is a vital organ with both endocrine and exocrine functions, playing a crucial role in digestion and metabolism. So, we have two functions. We have an endocrine function and an exocrine function. And enzymes is spelled wrong. I see that. Again, talk to text. It's really rough. So the pancreas is involved in hormone production, insulin. It's produced by beta cells, and insulin lowers blood glucose levels by facilitating the uptake of glucose into cells and promoting the storage and glucose of glycogen in the liver. Glycogen, or I'm sorry, glucagon is produced by alpha cells. Is produced by alpha cells. The glucagon raises blood glucose levels by stimulating glycogen breakdown in the liver and promoting gluconeogenesis, the production of glucose from non-carbohydrate sources. Then we have somatostatin, which is produced by delta cells, and it regulates the secretion of both insulin and glucagon and inhibits the release of other hormones. Then we have pancreatic polypeptide. It helps regulate pancreatic secretions and gastrointestinal motility. Impact of dysfunction on glucose metabolism. Sorry, trying to think and talk at the same time. Dysfunction of the pancreas, particularly its endocrine function, it can significantly affect glucose metabolism, leading to various health issues. We have diabetes mellitus, type 1 and type 2. Type 1 is going to be an autoimmune destruction of beta cells that leads to little or no insulin production and results in hyperglycemia due to the inability of cells to uptake glucose, leading to symptoms like polyuria, polydipsia, and weight loss. Type 2 diabetes is more of an insulin resistance where cells do not respond effectively to insulin, but eventually do. Beta cell dysfunction may occur, leading to reduced insulin secretion. Causes for hyperglycemia, as the body cannot utilize the glucose effectively and often accompanied by obesity and metabolic syndrome. We also have hypoglycemia, where there's an excess of insulin relative to the available glucose. The two we're going to talk about, hyperglycemic hyperosmolar state and diabetic ketoacidosis. So HHS, they like to call it's either called HHS or HHNS. I know it is HHNS, the hyperglycemic hyperosmolar non-ketotic syndrome. Again, spelling issues. I'm so sorry. A serious condition characterized by extremely high blood glucose levels, hyperosmolality, and dehydration without significant ketosis. We can't have ketosis here. Know that. We can't have ketosis. So if we don't have ketosis, we don't have ketones. So some causes of HHNS are going to be type 2 diabetes. HHNS has to do with type 2 diabetes. It can also be caused by infections and certain medications and dehydration or inadequate fluid intake, but it's mostly going to be tied to type 2 diabetes. Stressors can also be illness, surgery, or trauma. So with HHNS, it's a serious condition that's often seen in people with type 2 diabetes. Here's a simple breakdown of how it works. You have high blood pressure because you don't produce enough insulin. You produce insulin, but you don't produce enough insulin. Or maybe your cells become resistant to the insulin. This means that sugar can't enter the cells effectively. We then have a glucose buildup. So we're going to see a blood sugar of often exceeding 600. Then we have dehydration. So there's osmotic diuresis. The high levels of glucose in the blood pull the water out of the cells and into the bloodstream. This leads to increased urination as the kidneys work to get rid of that excess glucose, resulting in dehydration. We're going to have fluid loss because of the constant urination, and the body loses a ton of water, which concentrates the blood, making it hyperosmolar. Unlike diabetic ketoacidosis, which we're going to talk about, HHNS typically does not produce ketones because there is still some insulin in the body. This prevents fat breakdown, so ketones are not formed. Ketones are a result of the fat breakdown. We aren't going to have fat breakdown because we do have some insulin. So our consequences are going to be hyperosmolar blood. So the combination of high glucose and dehydration makes the blood very concentrated. This can lead to severe complications, including confusion, seizures, and coma. The loss of fluids and changes in blood chemistry can lead to the imbalances in electrolytes, which are vital for many body functions. So, in simple terms, HHNS happens when there isn't enough insulin to help glucose enter the cells, leading to extremely high blood sugar levels. This causes the body to lose a lot of water through urination, resulting in dehydration and concentrated blood without producing ketones. I have a little infographic here about signs and symptoms. So, we're going to see severe hyperglycemia, dehydration, confusion or altered mental status, weakness, and fatigue. Other symptoms are going to be polydipsia, polyuria, and visual disturbances. For diagnostics, we're going to do a blood glucose level. It's going to be very high, greater than 600. We're going to know our blood test for serum osmolality is going to be high. Electrolyte levels may show hyponatremia and hypernatremia. And then we're going to do urine analysis, but we should not see any ketones. Clinical evaluation will be the assessment of hydration status and neurological function. For medical management, we need to replace the fluids to restore hydration. We need to give insulin to lower that blood glucose level gradually. And electrolyte management, we want to monitor and correct electrolyte imbalances, particularly potassium. For our nursing considerations, we're going to assess vital signs, fluid status, neurological status, and lab values. For plan, we want to create a fluid replacement plan. We want to develop a plan for insulin administration to achieve gradual blood glucose control. And then we want to monitor them. We're going to make sure that the patient understands recognizing the signs of hyperglycemia and the importance of adherence to diabetes management, and discuss the importance of maintaining adequate hydration and following dietary recommendations. We want to assess the effectiveness of fluid and insulin therapy by monitoring improvements in hydration status and blood glucose levels. If you're going to give insulin to any patient, you want to do frequent blood sugar checks. And then you want to provide resources for managing diabetes and preventing HHNS in the future. And then that takes us to DKA, diabetic ketoacidosis. This is a serious complication of diabetes characterized by hyperglycemia, acidosis, and ketonemia due to insufficient insulin. So we're not making any insulin. Causes are going to be type 1 diabetes, most common cause, often precipitated by infection, stress, or missed insulin doses. And then you can have a cause with type 2 diabetes. It's much less common and usually occurs under severe stress or illness. But for the purpose of the NCLEX, we're not going to think about that. We're going to think of type 1 for DK. Other factors can be alcohol abuse, medications, and pancreatitis. So here's another little infographic on DKA pathophysiology. DKA is a serious complication mainly seen in type 1 diabetics. Here, we have insulin deficiency, so we're not making insulin. And this, the insulin that we have given ourselves is ineffective, and this can happen with missed insulin doses, illness, or high stress. We're going to have a glucose buildup. So without enough insulin, sugar can't enter the cells. And we're going to have blood sugars rise significantly, often exceeding 250 milligrams. per deciliter. So HHNS is above 600, DKA is above 250. With the fat breakdown, we're going to have keto productions. We're going to have metabolic acidosis because ketone levels are going to rise, and those are acid. And then we will have osmotic diuresis with dehydration, much like HHNS. And we're going to have severe symptoms. We're going to have confusion, nausea, vomiting, abdominal pain, and in severe cases, coma or death. We're going to have electrolyte imbalances. So DKA occurs when there isn't enough insulin to help glucose enter the cells. This leads to high blood sugar, fat breakdown, and acidosis, along with dehydration and serious health risks. Here's another infographic about signs and symptoms. So the classic symptoms are going to be polyuria, polydipsia, nausea and vomiting, and abdominal pain. Other symptoms that you should absolutely know. Um, Other symptoms that you should absolutely know are Kussmaul respirations, that deep labored breathing. We talked about that in the ABG lecture. Fruity, sweet smelling breath. That's a hallmark sign. You need to know that. That's due to that acetone breakdown. And then altered mental status, confusion, or lethargy. Our diagnostics are going to be blood glucose levels typically greater than 250. ABGs, we're going to see that metabolic acidosis with low bicarb. Serum ketones are going to be positive, and then we're going to see electrolyte imbalances. So hyperkalemia initially, then probably hypokalemia later. And our clinical evaluation is going to be assessment of hydration status and neurologic function. For medical management, we're going to do fluid replacement, insulin therapy, and electrolyte management. We're going to assess vital signs, fluid status, neurologic status, and lab values. We're going to plan for all these things. We're going to implement that fluid replacement and that insulin administration. We want to initiate insulin infusion, adjusting dosage based on blood glucose levels and clinical response. And then we want to educate the patient about recognizing symptoms. And again, here I have these infographics that I thought were super helpful. Here's one on DKA. Here's one on DKA versus HHNS. Again, your patient profile, your symptoms, what you're going to see to compare the two, another comparison, and another comparison. So I hope you find those helpful. I will be reviewing this in class again, and hopefully you find it helpful. I will see you in the next lecture.